Hello. Welcome in, everyone. Welcome, welcome. So excited to have you all here. I see a couple of folks trickling in. I'm going to give it a moment, but while we get comfortable, please in the chat, feel free to introduce your name, your pronouns, your title, your hospital, so we can all get to know each other. This should be a very interactive webinar today. So please let us know where you're coming from and who you are. Okay. Beautiful. Like I said, today's going to be a very interactive webinar. We're going to have a couple of slides with Slido, polls actually. So feel free, if you have a smartphone, to scan this QR code. It'll bring you to the Slido. We won't be answering any polls right now, but just so you have it up for later. And we'll also have the link to the Slido in the chat as well, if you prefer to pull up the link. All right, I'm going to go ahead and pass it over to Cynthia to get us started.
Awesome. Thanks so much, Ashley. Hello, all. I'm Cynthia Rohr, she and her, the ED Screening Program Director for Bridge. I am really glad to have you join us for what I cannot believe is our final program reflections webinar for the Emergency Department Syphilis, HIV, and HCV Screening Program. And I'd like to welcome you on behalf of Bridge at the Public Health Institute and, of course, our partner funders at the California Department of Public Health. So let's dive into the agenda. Today, we are here to thank you and celebrate you. And as Ashley mentioned, for you all to participate fully with your voices and experiences. We'll have two polls. The questions are there. We'll be asking you about both an accomplishment that you are each proud of and a challenge that you might still be working on. And then we're thrilled to have two guest speakers share their perspective on the program's impact, and CDPH's data and evaluation team, who you have been working so diligently with on data submissions, will share back some program data with all of us. And then we'll talk about staying in touch and continuing this movement for health equity in your emergency departments and your communities moving forward. So the appreciation we share today is both for and from the many people at the California Department of Public Health, Office of STIs and HCV, and Office of AIDS and others who make up this program possible, and as well as, of course, all of us at the Bridge EDSP team and really at Bridge overall. So I want to just ground us for a moment back in the beginning. In the program goals for this landmark $15 million in state appropriated funding way back in October of 2023, and really before that, to make this program possible. So we're here today to celebrate the progress and success of each of you in fulfilling these program goals, to identify and immediately treat those at highest chance for syphilis, HIV, and HCV, help control these epidemics statewide, taking this syndemic approach to further health equity, and really to improve system capacity for communities and patients by linking patients to not just care beyond the emergency department, but also to community programs to address social drivers of health. And when I say thank all of you, I really mean all of you across the state at each of the 28 sites. And I know that your team consists of many people here and many people beyond in the hospital. So we're talking about patient navigators, navigator supervisors, clinical champions, emergency department medical directors and chairs, ED directors of nursing and nursing managers, and of course, all of the ED nurses, staff, registration staff, social workers, all of the patients and patient advisory boards. You've been working with your directors of hospital laboratory champions, and other staff. You've been working with risk management, with your chief medical officers and chief quality officers, and of course with your information technology and electronic health record teams. Probably others in the hospitals that I want to include as well, and in your communities. So your partners at local health departments, at Ryan White programs, at community providers and federally qualified health clinics, and really all of your community-based organization partners. We also want to extend enormous gratitude to the Bridge EDSP Navigator Advisory Council. Some of you are familiar with the work that they've been doing. The Advisory Council represents urban and rural communities throughout the state with varied populations and ED visit volumes. And participating council members have been offering their time to the program. They are expert leaders who provide feedback and coaching based on their knowledge and experiences. And they have informed EDSP projects and strengthened opt-out screening and linkage to care best practices, just to name a few of the things that they have offered their feedback and guidance to inform the program tools and resources, such as the patient education handouts. They are some of the many navigators who show up each week to the Navigator Peer Coffee Huddle to offer each other peer resources, best practices, and mentorship. And they've really informed technical assistance as well. So please join me in thanking them. Carmen, Paula, Javier, Philip, Mandy, and Shirley. This program really would not be what it is without you and the many other navigators leading this work. So we at Bridge also asked each of your hospital sites to send some appreciations for your hospital teams. So let's kick that off.
All right. Wow, that was phenomenal, wasn't it? So now that you are filled with so much joy after watching that really great video, seeing all those wonderful smiles and teams, we invite you to fill out this poll and share with us an EDSP accomplishment that you are proud of. So you're just going to use your, smartphone device to scan that QR code, and then just start typing in whatever it is that whatever accomplishment related to EDSP that you are proud of. And you'll start to see those wonderful accomplishments pop up here on your screen. So go ahead, take a moment we'll wait.
All right, somebody said, being a change agent in my community and keeping individuals linked to preventative care and quality education that makes a difference one patient at a time. Someone else said, without the program, those diagnosed would have gone without awareness or treatment.
Mhm.
Building rapport with CDPH and Bridge and streamlining treatment for patients through the workflows and patient education handouts. Seeing the impact it has had on our patient population. Personally, seeing individuals get connected to resources and catching things early in the disease, linking patients, expanding our team and community collaborative, being able to bring awareness and education to patients, engaging with my community and meeting their needs where they are, making a life-altering impact in discovering, treating, and linking patients to care. These are incredible. I wish I could read even faster. Seeing the buy-in from all of our providers, nurses, and staff across the board. I'm proud of our team pulling together to optimize our EMR. And of course, all of the patients we're able to help.
Mm.
These are fantastic.
Wonderful. Yeah, these are so great. Thank you, everyone, for participating in this poll. You'll have another opportunity in just a little bit for a second poll. Keep adding in here. We love to see all of your accomplishments, everything that you're proud of. There really is so much that you all have truly accomplished. So we love sharing in that. Thank you. And then let's see.
I
Now
have
I'm
to
going
share this one, Latoya.
to,
Linking patients who would not have been aware of their HIV, syphilis, or Hep C status, their gratitude is priceless.
oh, yeah, it really is. Okay. So
Thank you.
yeah. Jen, would you like to introduce our next speaker?
Yes. So we have two people sharing their program impact today. The first one is Paula. And Latoya, you go ahead and introduce Paula. I'll introduce Dr. Zimian afterwards.
I think actually before all of that, we are going to introduce uh, Dr. Sorry, looking for my note.
It's okay. I can introduce myself.
Dr. Kathleen, yes, Kathleen Jacobson. Apologies. Yes.
Yeah, that's okay.
To take a look at some of the progress we've seen and highlight some of the progress we've seen throughout this program.
Yeah. And so, first of all, I just want to say truly amazing accomplishments that you all have done in the last 2.5 years. And in a few minutes, Sophie's going to go through some of the aggregate data that we have from all of you at this point in time, and you'll be very impressed to see it. At a high level, I'm very proud to say that 100% of sites are conducting routine opt-out testing for all three conditions. And that seems like a simple thing to say, but we all know that it took Herculean effort on all of your behalf to accomplish this. You had to get buy-in from leadership. You had to bring on the appropriate staff and then begin to implement testing and dealing just with those very first positives. That in and of itself is enough, but you all continued and persevered. Next slide. And 82% of sites as of October had automated their EMR to facilitate screening. And this is really one of the biggest steps towards sustainability in the future. And again, we recognize that that is months of work to make that happen. First, you have to, again, get leadership buy-in to agree to automate your EMR. Then you have to get your EMR priority on the EMR priority list, which can sometimes be a year and a half long before you can come up to the level of priority for EMR, and then it's actually implementing that EMR program, which in and of itself is no small task. And then from there, I really want to say that we really recognize that testing and treatment in an emergency department occurs on a continuum over time. First, it's getting that testing started and implementing the EMR changes to facilitate that screening. Then you really begin to work on the turnaround time of your tests so that you can start treatment in the emergency department. And I'm thrilled to share that more than 50% of sites as of July of last year had already done some treatment in the emergency department, with over 40% doing syphilis treatment, 20% HIV treatment, and Hep C treatment. We all know that you all are working towards that, and we hope that our updated test to treat algorithms will help support that. Next slide. Yet treatment, as you all know, cannot be possible without the support of all of the patient navigators, because they are really the linkage to treatment. And they ensure that patients don't get lost and get treated. And our patient navigators have done incredible training. 71 have onboarded. They've joined 75 peer support coffee huddles. They've done 82 mentorship and coaching sessions, and 7 of the ED navigators have achieved promotion at their sites. Amazing accomplishments in 2.5 years. And with that, I'm excited to turn this over to Sophie, who's going to walk you through the aggregate data to date.
Thank you so much, Kathy. These are some really great numbers. And before we go on to Sophie, we want to know what's still in progress. What are your sites still working on? So here's that second poll that I promised. Again, you know how it works, but if you need a reminder, scan that QR code and start typing in, besides additional funding, what EDSP challenge are you still working on? Let us know. We'll hang tight a moment while you feverishly type your responses.
All right, we see here that one side is working on buy-in from nursing and physicians. Another is trying to get all ED staff to see the importance impact of the program. And in general, up top, there are sites working on the patient linkage, awareness, connection to community, treatment. Thank you guys for sharing.
Yeah, keep sharing. Let us know what else you're working on.
Someone reported difficulty contacting patients, particularly those who are affected by houselessness or patient hesitancy due to stigma. Yeah, that's a really important one. Support from our local health departments to build a better information loop. Working through stigma, linkage to Hep C, and minimizing loss to follow-up. Building realistic partnerships with HIV service providers in our area to better serve our HIV positive patients. These are fantastic. Linkage with our marginalized groups, unhoused, substance abuse, violence, etc. Absolutely. Continue to increase linkage for Hep C. Yeah, lots of navigators are trying to improve linkage to care, and that is so important. Thank you guys for sharing.
We still have a couple minutes, so anyone else who wants to type in and share with us what EDSP challenges you're still working on, we'd love to see it. Okay. Looks like that might be it. Okay, we got it. Awesome.
All right, one more says establishing a solid post-screening system with community partners for linking homeless populations to care. Yeah, this linkage to care is something we didn't have in the ED before. So, it's such important work, and we couldn't have done it without the navigators. One more is typing. Buy-in has been an ongoing issue. Absolutely. Change in healthcare is hard, guys, and you guys are spearheading this new program. That's something we're working on as well at our hospital.
Yeah, and then when you factor turnover with nurses and providers and all the other staff, training is
Totally.
continuous.
All right, one more typing. Getting buy-in from new ED doctors, encouraging staff to continue to support this. Yeah, totally.
Mhm.
This is new to a lot of ED docs. Treatment of these disease processes is novel from the ED. So changing that culture is super important.
Yeah.
Thank you guys for sharing.
Yeah, thank you, everyone. Thank you so much for participating in our live polls. These are actually really cool. So happy to have this feature available to you all. And when we think about what that linkage to care looks like, it can really vary, right? And sometimes what you had in mind may not necessarily be the case. And so we invite our next speaker to share their story with you. So we have Paula Moreno, who is an EDSP navigator. She has an associate's degree in child development, super cool. She's CHW certified and has her SUD RC certification. She covers both locations, Adventist Health Selma and Adventist Health Reedley. So she's doing double the work with buy-in, linkage to care, building those community connections, and changing that culture. So, Paula, please share with us your story as a EDSP navigator.
Hi, everyone. Good morning. As as a EDSP navigator, when I initially started, I thought that the job role was going to consist of just calling patients to discuss their results, connecting patients back to their PCP. I thought it was just going to be follow up by phone, pretty much. I thought also that I would be heavily dependent on the ED providers for diagnosis, but that kind of changed as my as I started still working here. It became that it was not just about calling patients; it was about calling patients, and it's about reading, learning how to read labs, and becoming well served on it. Understanding treatment and medications for the patients, that building relationships with ED providers, nurses, social workers, public health, and other navigators as well. Knowing who to call so the patients don't fall through the cracks. And sending out labs, specimen confirmatories, creating extra hurdles for us. Yeah, when trying to reach the patient because they're out of the ER by then. And my why I continue doing this work, it's patient advocacy. Sometimes advocacy can look like asking the ED providers to start medication while the patient waits for their follow-up appointment with their PCP, helping patients schedule PCP appointments, um, also communicating with the clinics and letting them know why the patient needs follow-up. Sometimes the patient goes to the clinic and they don't even know why they're following up with the PCP. So letting the clinics know why exactly they need a follow-up appointment. So pretty much my role is helping bridge that gap, for patient care. And just want to leave you guys with this little quote. Screening finds the illness, but patient advocacy, um, I lost it. Patient connects to care. Thank you,
Thank you for
everyone.
sharing, Paula. Yeah, that's such a important quote because, we could find diseases in the ED, but without you guys, the patients leave the ED without treatment or linkage, and, it doesn't really change anything for them. So thank you for all the work that you've done. Next up, I want to introduce Dr. Kian Azimian. He is a board certified emergency medicine physician, an assistant medical director, and the EDSP clinical champion at Bakersfield Memorial Hospital. Outside of the ED, he continues to be a superhuman. He has completed at least 5 Ironmans, 10 half Ironmans, ultra marathon races, which is like 50, 100 miles, who knows, and many marathons and half marathons.
So sorry
Very
on a
impressive.
call. If you could just not turn on the volume for a second. Sorry, just for a second there. I had to make sure that you guys could hear me. Thank you so much for that introduction. Just wanted to say thank you, everybody. And really, I think when I think of both EDSP and also just Bridge, et cetera, really what it comes down to is teamwork. Whether it's the docs that you have to kind of get roped into the team, or the IT folks, or nursing staff, or lab, et cetera. It really is bringing everybody together so you can provide the best care possible for the patients out there. I think the main thing was at the beginning when we started all of this, I was a little afraid of how much am I going to be able to contribute? What am I going to be able to do? And I realized that everybody, as you get different people involved, they all want to contribute. They all want to be able to help care for their patients in a better way, and really doing all of the testing that we've been able to implement really helped our communities. Our communities, at least in Bakersfield, just in the emergency department, we have about 75% Medicaid patients. So definitely patients that don't have a whole lot of access to healthcare, and being able to do the testing for HIV, Hep C, and syphilis in the emergency department really helped identify the patients that need more care, that need that next step of being able to make sure that they remain healthy, and getting that done really is a teamwork of a lot of people. And this is the time to really thank our linkage to care folks, Philip Castro, Pacheco, Jessica, all the people that have really hard the true hard work in there to get a hold of these folks, get them onto the right treatments, get them to the right folks as well. So I think that's the picture that we've been able to kind of coordinate with the teamwork. I think the part that I would love to see, you be able to improve with time is a treatment for Hep C in the emergency department. That seems to be a little tricky. But hopefully we'll be able to implement more of that with time. Having said that, we've got excellent linkage to infectious disease doctors in the community that can care for those patients. So that's pretty much it. And thank you, everybody, for being a part of this very special opportunity to help make people healthier.
Really wonderful to hear your perspective, Dr. Simeon, and also definitely loved working with you in the Memorial ED. It was such a wonderful experience, and so many really great providers in that area because of your leadership and Dr. Burson's leadership as well. So next
Thank
we'll
you so much.
introduce we'll introduce Sophie to go over some of that data that Dr. Jacobson mentioned earlier.
Great, thanks. So now that we've heard about some of the incredible program progress from Dr. Jacobson and those impact stories from Paula and Dr. Zinian, we're going to take a look at how all of that translates. Actually, go back a slide before we. Yeah, thanks. We're going to take a look at how all that translates into some key program outcomes. So what you're going to see in this section includes preliminary data from sites for whom data are currently available through August 2025. And as we receive final data and complete quality assurance and data cleaning for more EDs, we're going to add more sites to these data. And before we dive in, I really just want to extend my deepest gratitude to everyone who's worked to implement testing, treatment, and navigation, and to everyone that has worked tirelessly to compile these data. It's really hard to believe we're at the end, and I'm excited to share this celebrate this milestone and share back with you about all the work you've done. Throughout the slides that you're going to see a varying number of emergency departments represented. For each data point, we wanted to include as many sites as possible, but availability of data varied. So I will just walk you all through that as well. Next slide, please. Okay. So among the 21 emergency departments for which we have clean and analyzed data on testing, from January 2024 to August 2025, 165,633 patients were tested for syphilis, with 5% screening test positive. 183,142 patients were tested for HIV, with 1% screening test positive. 209,327 patients were tested for HCV, with 6% screening test positive. And while it's not shown here, I did want to highlight that the number tested for each of these infections in the implementation period was an increase over baseline. I'm just going to pause for a second and let you all take in these really incredible testing numbers. Next slide, please. So here we're looking at a key priority population, pregnant patients. So among the 18 emergency departments for which we have data on pregnant patients so far, from January 2024 to August 2025, 12,253 pregnant patients were tested for syphilis, with 294 having a positive screening test. 10,310 patients were tested for HIV, with 27 having a positive screening test. And 11,644 patients were tested for HCV, with 177 having a positive screening test. We wanted to call out this priority population given the significant impacts that identifying infection and pregnancy can have on perinatal transmission prevention. In particular, I just want to highlight this potential to prevent 294 congenital syphilis infections, which is really incredible. And so again, I want to pause for you all to take in these data. Okay, next slide, please. So moving on to confirmatory testing, here we're looking at data for 17 emergency departments for which these data are available. This shows the proportion of ED encounters with a positive confirmatory test among those who received a screening or initial test, regardless of whether that screening or initial test was positive, for all reporting periods from baseline in 2023 through August 2025. Across all three infections, confirmatory test positivity among those screened has remained relatively stable. Next slide, please. But the story changes. There's a little bit more to it when we look at the number rather than the percentage of patients who had a confirmatory positive test. Again, among 17 emergency departments for whom these data are available. Here we're comparing the pre-funding 12-month baseline period on the left with the most recent 12-month implementation period we're reporting on the right. For all three infections, we see an increase over baseline in the number of patients with an identified infection, particularly for syphilis, where we see a 76% increase in positive confirmatory tests over baseline. Next slide, please. And moving on to treatment, among 14 emergency departments for which treatment data are currently available, of those patients who had a positive screening or initial test for syphilis, 32% initiated treatment in the ED. Of those patients who had a positive or initial screening test for HIV, 10% initiated treatment in the ED. And of those patients who had a positive screening or initial test for HCV, we had no patients initiating treatment for HCV so far. Next slide, please. And finally, I'm going to shift to findings on navigation and linkage to care, with these data coming from a different data source. The prior data that you were all looking at came from electronic health record data. These data are coming from the linkage to care tracking tool. These data are from March 2024, which is when we instructed sites to start using this data collection tool, through August 2025. So we're looking at just 7 emergency departments that we currently have cleaned and analyzed data for. And so given this is just 7 EDs right now, we really want to emphasize the preliminary nature of these data, and that we will see changes as more EDs data are added to this. So for these 7 sites, we see that 803 patients needed follow-up for syphilis, 305 patients with HIV needed follow-up, and 714 patients with HCV needed follow-up. In this context, we're defining needing follow-up as patients who have a new infection or patients who were previously diagnosed with syphilis that was untreated or had unshown treatment or incomplete treatment, or for HIV and HCV, a previous diagnosis, but the patient was out of care. So this could include patients that received some treatment in the ED and still needed follow-up. Among those who needed syphilis follow-up, 51% were referred to care, which we defined as having a follow-up appointment scheduled. Among those needing HIV follow-up, 63% were referred to care, and 53% linked to care, which we defined as attending a follow-up appointment. And among those needing HCV follow-up, 40% were referred to care and 16% were linked to care. So I do want to note that while these data do show some room for improvement, I think that they are probably an underestimate of the true number of patients who attended follow-up appointments, particularly that linked to care number. These data represent the patients for which a navigator was able to determine that an appointment was attended. So there could have been additional patients who attended an appointment without the navigator's knowledge, and I just want to highlight that. Additionally, referral and linkage to care are just 2 outcomes along a continuum of all the work that navigators do to support their patients. As you all know, there is a lot of navigation work that is beneficial to patients' outcomes and well-being that isn't represented here on this slide, including connections to support services, counseling, and education, among many other things. Next slide, please. So while these data are preliminary and highlight only a portion of the funded emergency departments, there are some initial takeaways that we have. As Dr. Jacobson discussed earlier, we know that implementation occurs on a continuum, and we can see that in the data. At this point, as you saw earlier, we have 100% of EDs doing testing for all 3 infections, which is incredible. And then comes working with labs to improve test to treat. Turnaround time, meaning that treatment can begin in the ED. In our preliminary data, we saw that there was an increase over baseline in patients screened and patients confirming positive with an identified infection, especially for syphilis. It also seems like a strong infrastructure has been established for screening in the EDs. However, we do see that there is substantial room for improvement when it comes to treatment in the ED, but I'll note that we have been streamlining those test to treat algorithms to support better treatment initiation, which is particularly critical in light of challenges that many of you highlighted earlier with referral and linkage to care, where we also see some room for improvement, though those data are very preliminary. Like I said, I think those linkage to care data will change and might be underestimates of what is actually happening. Next slide, please. So, like I've said a number of times, since these data are preliminary and don't represent everybody, we are actively working on data cleaning, quality checks so that we can finalize the analysis. We're really excited to continue reviewing and analyzing and reporting on all of the important work you all are doing. There will be more reports coming out as we receive final data submissions. We're looking forward to sending you all ED-specific summary reports to support you all in celebrating your wins and taking a data-informed approach to quality improvement. We also plan to analyze and disseminate findings from the pre and post staff survey that I'm sure many of you have taken and distributed to your staff at the emergency department. And we're going to be putting together a comprehensive evaluation report of the program, looking at implementation and outcomes for all 28 sites, and probably more to be determined. Small plug for our data office hours. Our final data office hours are this Thursday, March 24th from 2 to 3 p.m. This is a great place to bring any questions about the final data submission, thoughts about the data you saw today, or any other questions, thoughts about data related topics for this project. Next slide. As always, we welcome thoughts and questions and suggestions. You are always welcome to email us with thoughts about data, ideas for analysis and reporting, interpretations of what you're seeing. We always want to know what you think. And just want to say thank you again for collaborating with our data and evaluation team. I think we have some time, so I'm happy to take if there are questions, any questions that are coming up, and or again, you're always welcome to email us. I'll be sure that our email is in the chat.
That's right, Sophie. We do have time here for reflections and questions, and I'll just lift up a couple things in the chat as other folks think about, any impressions from these preliminary data that Sophie has been sharing that you all would like to reflect on or comment or ask about. Dr. Tavisal asked, could we have these slides or the stats emailed to us? That was asked before you kind of did the summary, but just if you want to repeat what's coming out to sites, that might be helpful.
Yeah, definitely. So I will defer to others about whether the slides from this webinar are getting sent out. But in terms of other products, data products for sure, we are going to be sending each site will be receiving like an individual data summary report, so you can see your site's individual data to help inform your programs. And then as we have cleaned and analyzed data for all 28 sites, there will be comprehensive data reports coming out as well. We are going to be working to get stuff out as quickly as possible because we know folks want to be able to see these data, and it can also support you all in advocating for programs and improving programs at your sites as well. I hope that answered the question.
Great, thanks, Sophia. And also, I see a shout out here from Jose Molina, looking forward to that outcomes report. So anticipation there. As people think of other questions or reflections as well, I just want to name, I think the office hours is this Thursday, which would be the 26th. And it's from 2 to 3, is that right, Sophie? I think we had a little typo on the slide there, but I know you have an invite that's sent out to everybody and a reminder. So,
yeah, thank you for correcting that. That today is the 24th. Yeah, 26, 2 to 3. Yeah, thank you, Sophia.
Yeah, for sure. Okay, so moving on to the next question from Jesse Mora. I'm curious about. Onto the next question here. I'm curious about the treatment for syphilis in the emergency department. were patients treated automatically before getting results, or were patients in the ED long enough to get those results?
I'm going to answer that from a data perspective, but then I'm going to call in other folks because I think that there's probably more of a programmatic side to this question. From a data perspective, we don't have an exact time of when people are receiving treatment in the data. And so we don't know whether people are like in the data itself are getting the treatment before their results or after because we don't have those timestamps. But I think that other folks on this call might have thoughts about this from a programmatic perspective. So I will ask Dr. Jacobson, Dr. Zahn, Ashley, if they have thoughts.
Yeah, I don't think we can tell from the data, but I suspect it's a combination of different approaches. Some folks might be being treated based on the symptoms they have even before their results come back. Others will have results back when they're still in the ED, and so they'll be treated based on results. And others will likely not get their results until they have been discharged and they may have had no symptoms that suggested to the provider that they should empirically treat that individual. So I'm sure it's a spectrum of answers to that question. Yeah, and I think I see Javier answering in RED, if antibody test is positive, but the RPR is not back, we treat unless the patient declines. And CDPH encourages that because we know that folks are often lost to follow-up. And so we do support treatment based on initial screening test, which is what I think Javier is saying there.
Just note if there are no other questions about data right now, I know sometimes it has to settle and think and mull over it, as I often do with data. I will put as many of you have it probably, but I'll put our EDSP data email in the chat as well. Like I said, you're always welcome to email us with thoughts and questions. Oh, thank you, Ashley, for doing that. And or bring thoughts and questions to data office hours on Thursday if you want to.
Thank you so much, Sophie, to you and the rest of the team and all the hospitals for all of the work that went into that preliminary analysis. And I do see a great maybe final question for this section. Out of curiosity, this is from Angelique Skinner. Out of curiosity, was there anything in the data that surprised you?
That's such a good question. I wouldn't say there was anything that like really surprised me, but I think more I was very heartened to see the numbers. Like, even though we don't have every emergency department in our data analysis yet, like the fact that those testing numbers are in the hundreds of thousands is just like incredible to me. I don't know if I find that surprising because I just like know all of the work you all are doing, but I just think it is really incredible to see those numbers written out and think about the impact that it is having across the state of just sheer numbers of people being tested.
Yeah, thank you, Sophie. I will echo that because this is the first time I'm seeing these preliminary numbers as well, and I feel just incredibly excited and proud. And I know some of you all talked about like when you talked about the barriers or challenges that you're still working on, you were talking about continuing to get buy-in, and these numbers and this data is one of them anyways, along with your patient impact stories to continue to do that throughout your emergency departments and hospitals. So I'm going to go ahead and transition us. Normally I do next steps at the very end of the webinar. I'm mixing it up today. I will just kind of dive right into showing. This is actually, the next slide is actually another slide from our kickoff from fall of 2023. This incredible timeline of how far we've come since that time. And so just taking us back to the beginning, all the way now reaching the end of this timeline. And I will just name that 100% of sites have completed 100% of your implementation milestones. That is just absolutely incredible. We have we have 3 sites who are still working really hard on their data submission for 24 months. They're in close contact with us and our partners at CDPH to do that final piece. And then all of you are reaching the 30-month or final submission, which is due April 15th. So for that 30-month final reporting, you will all attest that you have maintained your programs, including all of the milestones you've implemented so far, and you'll continue with your, of course, final data submission. And I need to flag that this timeline for submission as the contract comes to a close, it could not be more imperative that you submit on time so we can process payments before your contracts end on April 30th. So you must submit before or by April 15th to fulfill your contract and receive your final payments before the contract closes so that we at Bridge can process that for you. So if you have any concerns about meeting the April 15th deadline, please contact us immediately so we can work with you and support you. That final 30-month final report to Bridge is linked in the chat. It's also been sent out to all of you over email so you can take a look and get started. And on the next slide, I'll just kind of map out those next steps for you. So you go ahead with your team and collaborate on that final narrative report that are in those questions linked in the chat. CDPH has sent out final data submission reminders, so you'll review those steps tailored to each of your emergency department, what you need to get ready. And then again, by or before April 15th, you will submit your final data, deliverables reporting, and final invoice. And then starting the next section, we're going to talk about, continuing to look into the future in the post-funding period. Please continue to share your program successes, not just with your community partners, but with us at Bridge and with CDPH. You can do that as you continue to join the monthly CDPH community of practice. And we really look forward to you continuing to reach out to us, to keep in touch, to continue to support you and collaborate with you on this work. So in that, as we talk about moving forward into the future, I'm going to hand back over to Dr. Jen Sutton.
Thank you. I'd like to conclude with a summary of sustainability strategies that many of your sites have already planned or implemented to continue this important work. Here is a recap of some strategies we talked about on our sustainability webinar from September. For those of you who missed that webinar, you can view the recording on YouTube. The link is in our EDSP webpage, and we will also drop it in the chat. On the webinar, we talked about external funding that can help sustain your screening program. We reviewed the 340B drug pricing program where eligible hospitals can use savings from discounted outpatient drugs to enhance patient services, such as hiring navigators or covering laboratory costs for STI testing. Other funding may be available through local health department grants, opioid settlement funds, industry grants, such as the Focus program from Gilead, the AIDS Drug Assistance Program, or the PrEP Assistance Program. In terms of billing options, the first is simply insurance coverage for routine opt-out STI screening, and I will share the new CDPH cost analysis tool to help you estimate a net reimbursement for screening. Some hospitals have also explored CHW billing. Services provided by navigators who are CHW certified, such as health education, health navigation, screening, assessment, can be reimbursed through Medi-Cal using this billing pathway. And enhanced care management is another billing option for Medi-Cal members who are enrolled in ECM and receive comprehensive care management. On the next section, don't forget to utilize the EDSP Making the Case tool, which is a double-sided one-page handout that can highlight your EDSP program by presenting its background, impact, and site data, which will be shared with your teams by CDPH. Additionally, CDPH shared their new cost analysis tool at the recent Community of Practice on March 18th. This will be shared with all of you soon, so look out for it in your email. This is a tool that can help calculate the net profit of your screening program by inputting your site-specific data on the number of screening tests administered and calculating reimbursement of these tests by various insurance structures. Sometimes hospital administration wants to understand the business side of a program, in addition to its positive impact. And this tool can help you make a compelling case to sustain your screening program. Lastly, I want to take a moment to highlight the strong work your sites have already done towards sustaining your programs. On the 24-month deliverables report, 100% of EDSP sites reported that they have planned specific action steps to continue to offer routine opt-out testing to ED patients. This is absolutely incredible. 57% of sites reported they have sustained their EDSP Navigator as a permanent position, and many of the remaining sites were still working on this. This goes to show how impactful navigators are in their communities and for our EDSP programs. In terms of how sites are planning to sustain their program, on the next slide, you'll see that 42% of sites are exploring additional grant funding opportunities, and 28% are pursuing CHW billing or insurance reimbursement of screening tests. On behalf of our EDSP team, I want to express just how honored and grateful we are for the opportunity to collaborate with all of you through this program. You are an incredibly inspiring and dedicated group of people who have made a tremendous impact for your patients and communities, perhaps more than you even know. As a team, we promise to continue to advocate for patients, for public health, and for doing the right thing. With that, I will pass it to Dr. Jacobson for some final words.
Yeah, thank you, Jen, and really everybody for a great wrap-up webinar. I think really I want to thank all of you from the 28 emergency departments for your incredibly hard work. We do all appreciate what it takes to just simply get one of these programs off the ground, let alone screen hundreds of thousands of people. And I want to, just remind you that that data only went until July of last year. So those numbers are only going to grow from here as we clean the data for the rest of the program. Thank you, everybody. Really incredible work. I want to encourage you to just keep the momentum going, keep the progression going. When you get your data, review it. Think about your EMR. Could you modify your EMR algorithm so that you can increase the overall positivity rate of your program as it screens folks? Encourage all of you to come to the April Community of Practice, during which we will cover the most up-to-date test to treat algorithms for all three of the infections. We've heard all of your feedback. We do want to simplify them for all of you, and we've been in the process of doing that, and hope that helps to simplify the test to treat for all of you moving forward. And reach out if you would need any additional help from either CDPH or Bridge. We're happy to help. And mainly I want to do this. I just want to clap and thank you all. You've done incredible work. And I know a lot of folks are going to be really excited to see the outcome of all of your programs. So thank you.
Thank you all so much. Thanks, Dr. Jacobson, for ending us on that note. And as always, we welcome your feedback and really invite it on this post-webinar survey. Looking forward to continuing to stay in touch and seeing you all at Community of Practice next month and beyond. And of course, you know where to reach us in the meantime. Thank you all so much. Really, really appreciate you.